So I've already apologised, my hand's been really cold. I'll just sanitise, so we're implementing good hygiene techniques. Okay, so we've hygiened. Okay, so I would ask the client, obviously, are you comfortable for me to touch your feet?
Yes.
Some clients aren't. And then I would say, I'm just going to take your socks if you're okay with that. Okay, I've asked her to shuffle off the bed as well, so I can actually access her ankle because she's quite tall. So if she's comfy up on the bed, I can't get to her.
So we did someone else take the socks off.
There's something there for you. Okay, so I would just get her to then please point her toes. So I'd say point your toes towards the door, wall. Yep, and I'm just looking, I'm just seeing, is there a difference between the two sides?
Yeah.
Can I see, so I don't really know what this means at this time. It could mean this, it could mean that. So yeah, I'm noticing that this one's a little bit higher, this one's a little bit lower. Does that mean that this one's tighter, weaker? Does it mean this one's tighter, weaker? I don't know that until I go through more of my assessments. Okay, so then I'm going to get her to point her toes towards her head. Can she pull her toes up towards her head? And I can see from this angle here, she's got a lot more range of motion pulling her toes back on this side towards her than what she does on the other side. Okay, so I know that there's restriction in this foot. This is the one that's giving me the difference. Is this the injured side?
Yes.
Yeah.
Sure.
I didn't even know that that was the injured side, right? We haven't done our consult with her, but I can see when she points, I'm not sure. I don't know, is it, which side is it that's giving me, you know, it looks like this one's got more range, but then as soon as she pulls that up, yeah, I can really see the difference, right? So this one's where the restriction is. It's not letting her get that ankle pulling her towards her. Okay, then I'd ask her to point her toes in towards herself. Okay, that's not too bad. It's pretty even, she's got quite nice range. And then I'd get her to do it out. Okay, I can see here there's more restriction, right? She can't turn this foot out. Something blocking her here from turning out. Okay, whereas I can see here she's got more arch. Can you guys see that? I'm not sure from your angle if you guys can see. I can see because I'm hovering right over. I can see a nice curve here where her toes are out. This I can see she's restricted. She can't twist it out. Okay, relax. I would then do the same thing. I would then do the passive movement and I would say, okay, point your toes, and I would just guide and see how much further I can get her down. Okay, I would typically start with the good side. So I would say, okay, point your toes, and then we're going to see, oh yeah, okay, I can feel that there's some give, I can feel some movement, and then I'd come to the bad side, point your toes, and I'd do the same thing. Okay, point your toes up towards your head for me, and I'm just pushing to see if I can get that ankle to move any further. Okay, so I can see, you can, I don't know if you guys can physically see that, point your toes, and then I can actually push her a little bit further. I don't know if you can see, it's only like a smidgen, but I can feel that I've got a little bit more movement that I can push. And then same with this side, pull your toes towards your head, and then I'm pushing, yeah, and I can feel there's a little bit more movement there. So there's still a little bit of restriction, but I can still get a little bit of give. Okay, point your toes inwards for me. I'll do one foot at a time. I'll do your good foot first, yeah. And I'm just pushing in to see if I can push those toes in. That's pretty locked. There's not much more give there. That's going as far as it can kind of go. Push your foot outwards. And I'm just guiding her out, yeah. There's a little bit more give on that side. Push your toes in. Oh, see, there's quite a bit more bend. I don't know if you guys notice the difference there. It's quite a bit more bend that I've got there than what I did on this side with her turning in. So she's got quite a bit more give there, which may indicate that there's a bit more loose elasticity around here, and those ligaments that maybe are letting me actually bend her forward a little bit more. So this side's a lot more stable on the outside, and this side happens to be the side that she injured, which we didn't know before we did our assessment, but it's pretty clear to us now. We can see that there's that looseness there. Do your toes outwards. Okay, and she's feeling pretty good there. It's not too bad. You can still see a little bit on that outside still giving, even though I'm pushing out. You can still see those outside ligaments. Okay, so that's what I would do for our active and passive range of motion. So I'm just visually seeing how much range of motion she's got. From that, I've been able to identify that, yeah, this looks like the dodgy ankle. Okay, through our consult, we would have known that that was a dodgy ankle, but because Nikki has had an ankle injury, I wanted to see if we could spot it without having to ask her which side it was. Okay, cool. All right, so then, if we come to look at our lateral ligaments to see, especially in our netball players where we see them, you can sit up. So if you want to sit up on the bed and wiggle your toes up. So to access our two ligaments they come out in like a little V from our lateral malleoli. They come out in like a little V, and it's our anterior tibiofibular ligament and our calcaneo that attaches to our calcaneus, okay? So they're the two ligaments that we're looking for. To find them, you just invert the foot. We just turn that foot inwards, and we've got two little ligaments that come out in like a little V, and there's that little bit of soft tissue that you just kind of feel around for until you feel it, and it's kind of in these little divots and up into here. These little divots that we can kind of feel. So they don't feel too tender to touch, they feel okay, she's not feeling too bad. We may also touch on the top here, so it can feel quite tender on these tops, or a little bit ropey where there's scar tissue. You might feel some swelling, but there's nothing there. That one's not feeling too bad. It looks pretty rigid, you can see, especially when you compare it to the other side. Okay, so we relax that one. When you come through to this side, you can already see, like you can visually see the difference. I don't know if you guys can from this side, but that swelling that I was talking about earlier, yeah, you can see it. And how long ago did you do your ankle?
2 years ago.
Yeah, so it's still 2 years.
And if I stand for like too long, it just goes straight.
Yeah, there you go. See, so we can see that that's squishy, but as I feel it, it doesn't, you know, who was talking about the popping candies? You were talking about that bubble wrap. It doesn't feel knotty. It doesn't feel bubble wrappy. It doesn't feel like there's that scar tissue that's built up in there.
It's like fatty.
So it's just like that fluid. It's just that liquid, that swelling that's still in there that you can see. So we'll turn her in, and we'll be able to feel a little bit more of a tenderness up into these ligaments, up into here. Still doesn't actually feel too bad. It doesn't feel too ropey.
Nice.
Yeah, usually up in here where they've had an old injury, it's where you get that gritty, bubbly, knobbly feeling. Hers is actually not too bad. It's not too bad. So she might have more of it on top. So I'd feel a little bit more onto the top bit. It's a little bit just on the outside here, but again, it doesn't actually feel too bad.
The physio went real hard in there, and like when he's left, his like fingerprint was
Was
still
there
in there, and I was
indented.
just like, it was nasty.
So there's just a little bit on that top bit, but very, very minimal. So she's had some good rehab on there. Yeah, you can just feel that little bit there, that little bit just in that top bit there. Just in those top attachments there. So you could do your trigger point there, you can feel that little bit of scar tissue up through there. And then it's not too bad up through into these ligaments up to here. Yeah. So she's not too bad. When I'm going to check for that pooling in the middle, I'm just going to hook around to the internal malleolus, the ankle bone in the internal side, and I'm just sort of getting up and underneath to see if I can find and feel that tib anterior tendon. And I'm just going sort of up along the outside of that, I can do it this side for you guys to see. Just going sort of up and around like this. And then I'm just going to travel up into there just so I can feel if there's that posterior tib tendon, if there's any knottiness up through there, if they've had that internal injury. And I'm just hooking my thumb up and around, just going up through the whole side, up into there. We've got no wax on, obviously. No, it all feels pretty good. We've got a little bit here. And we're just going to travel up into there. So with people that have had that on their anterior tib, that posterior tib, they'll feel it. It'll be quite tender for them when they're coming up into there. They'll be able to feel a little bit where it's like, ooh, just feels a bit sore. Okay? Alright, so that's those two. Someone press on our little screen and let's see. Sorry, I'm your feet.
You can't help it when you touch it.
I think if you slide down with your feet off, we can do the anterior draw. Thanks anyway. How do I keep it on?
It actually feels so much nicer when it's like real specific instead of just like,
Yeah. Okay, so I'll do the anterior draw test while she's sat, and then we will do the lunge test together as a group while we're stood up. And these other guys that don't have a tape measure can film it for us. And then your proprioception with your balance. Yeah, okay, so again, I'm going to start on the good leg. And you just want to stabilize. So we're thinking about if any ankle ligaments have gone, the ankle's going to give, it's not attached. So we stabilize through the front. So we want to hold the front to keep that nice and stable. We want to pull the ankle towards us. Okay, so I'm stabilizing it through here, and I'm gripping her hand, her feet in me. So I've got a good solid hold of that foot. Doesn't matter which hand you want to use, whatever hand you feel most comfortable with. Stabilize the anterior shin, and I'm gripping her heel, and I push gently back and I pull gently forward. So I'm going in this direction, trying to get that ankle to give. What I'm looking for is this anterior aspect here to see if any of these ligaments shift, okay? Which on this one we might get a little bit of movement just to see if there's any give in the ankle, which just lets me know there's instability there. So I stabilize, I grip, and I push this way, okay? I can see that she's sinking because I'm moving her, but the ankle's not shifting. So it's a fine line to see that there's a shift, but that it's not just me moving her skin, that there's actually like a give. So there's no real give in that ankle, okay? There's not coming towards me. Okay, and I've tried with my right hand where I'm stronger to pull, and there's still no real give. So I come to her bad side, do the same thing. I stabilize on her shin, grip her ankle, and yeah, so there's a little bit of give there. So I can still see her skin moving from where I'm pushing, but I can feel just a slight shift. I'm going to change hands where I'm stronger on my right. Yeah, and there's just a tiny little give, just a tiny little bit where I can feel that that ankle's just shifting ever so slightly towards me. Okay, so that's good. So that's our anterior draw. The most common ones that you will do for your ankle is those inversion and eversion ones. Okay, as soon as we do that inversion, we can see that there's restriction. As soon as we do that eversion, we see that there's restriction as well. Okay, so come through into the lunge test because that also just confirms that dorsiflexion restriction. I'll get one. Oh, Kara's still got it there. We need a tape measure, please. So what we do is we had a tape measure down on the floor. Sorry. Oh, someone might need to hold that for me. So don't put a little thing as wide as it will go. Yep. Yep. Okay, and so we'll ask Nikki to come over. Yep, you'll face the wall for us. And you're going to put one foot up to the, yep. And you're going to touch the wall. Okay, and then we're going to ask her to shift back. So come up to the tape measure for us. Okay, and we're going to shift her back. And then we're going to ask her to touch the wall. Okay, I'll just put that there. Okay, so let me come this side so I can see you. I'll come out of the way of the camera. Okay, so if we get her, we're watching the front ankle, right? So we're going to get her to touch her knee to the wall without the heel lifting. Okay, so we want to see how much range we have through this ankle before this heel starts to lift. So we're not worried about what this leg's doing. We're worried about what the knee's doing to that ankle when it touches the wall. Okay, so we said that the average mean was 10, so she's already got past that. So she's doing really good on this side.
I feel like any further probably would start
to lift. So you can see just slightly there that she's starting to lift. Okay, so this is the good foot. And what did we get to? We got to 14. So then we ask her to do the same thing on the bad foot, and we see how restricted it is and how far she can get. Okay, you can see it's a lot harder for her there. She's struggling to touch the wall. Yeah, I can see she's really like forcing that knee to touch that wall. She's willing that leg, but I can see the ankle's already starting to lift, and she's at about, what, 7, 8. So she's gone from 14 to 7, 8. So that just confirms that we've got massive restriction in this ankle, which we know because it's injured side anyway. So this is where the tightness is into this ankle, where we know that there's a restriction. So we've got a massive imbalance between 14 centimeters to 7 centimeters. Thanks. And thanks. So we want to now catch that other side up, right? So as we were talking about before, I think we said something about 3 to 1 where we're rehabbing. When we've got the injured imbalances, to catch the other side up, we typically try and do a 3 to 1 set. So we want to do 3 reps to 1 rep on the good side to 1 rep on the bad side. So we're, no, other way around. 3 reps on the bad side to 1 rep on the good side, so we can catch that other side up. So our focus for her is going to be on her our right ankle. To get, we're still going to do the same exercises on the left because we want to keep the balance, but we will increase the reps on the right side, making sure that that's where our focus is in the ankle. Okay? We would then also follow into our knee rehab because yes, I know that there's restriction at the ankle. I've seen it. I've felt it and I've seen it. I know that there's some instability in there, only slight. So I would then come into, oh, we actually haven't done your balance test. No, so I'd go into my balance as well. Yeah, we've done our lunge anterior. So then for the balance, as we said, we'd do the one side, eyes closed and eyes open. But then we would move into our knee, we would be looking at our kneecaps, which would be ideally if we had shorts on. So when we go into the single leg stance for our balance, we said the same thing. We're going to do one leg with our eyes open and then one with our eyes closed, and we're looking for which way she falls. So we can see how her body compensates when she falls, when she's unstable. If we think about an old lady, Danny was saying she's got lots of old clients. If you think about an old lady that's got to go onto one foot to step up a curb, for some oldies, getting up that little curb is actually quite an effort, it's quite hard. So if we think about, okay, she's going to step up onto that one leg to get onto the curb and fall. When she falls, how is she going to fall? What's she going to injure if she's falling? So we're looking for these compensatory movements of how they naturally move when they're in an unstable position, as well as how long that they can balance on that leg. Okay, so when you're ready, balance on one leg. I'm going to be close to the client, so if she falls, I'm here to catch her. Okay, start on your good leg for us, and we would typically time on their good leg. Yeah, they could go for days. So I usually look how comfortable they are, maybe count to 30 seconds. If they go above 30, I say good, excellent, 3 ticks, no issues on that good leg for the eyes open. Okay, and then we go right, eyes closed, same thing, I'm here if you need me. I can see she's swaying to one side. Is she swaying to that side because she's got that leg up? Is she swaying to this side because this is the good leg? So we had a bit of an all over fall, but she fell to this side, right? She fell to her good side. So she's favouring that good side, which is not unusual because that's her stable side. Okay, so let's see how bad she is on her bad side. Okay, so when you're ready, eyes open. We're also looking at the movement of the foot. How much is it shifting? Like how much more is she having to work to really keep that? And her eyes are open. Oh, were your eyes open? Yeah. So how much is she really having to work in that ankle? That gives us an idea of where our proprioception is and how bad that instability might be in that ankle if she's really shaky. She's keeping it up, but she's shaking. How hard is that ankle working to keep her stable without me having to cue her how to improve that balance? Okay, so then we go, right, same thing again. Onto your good leg, onto your bad side, arms, leg up, eyes closed, and I'm here if you need me. We're watching which side she goes, and again she favoured the good side. As soon as she went down, she favoured that side. She didn't sway to that side, even though that was the leg that was up.
It feels like it's trying so hard.
Yeah, you can see it. You can see it really, really working hard. Okay, cool. So that's pretty much your ankle. Okay, from the ankle we would then move into the knee, because typically if they've had an ankle injury they're going to be having knee problems. Okay, we haven't seen her gait, we'd get her to walk now, but even just seeing her stood there, she's not stood like this with bow knees or anything, or turned in feet or any rotation through that hip or knee. She's standing pretty straightforward. So maybe just walk to the skeleton and back for us so we can have a look and see if there's anything obvious. If there's any swinging of that, ankle, if the ankle turns out as she swings. Looks pretty good. We didn't see any in-turned feet like this. She wasn't working, she wasn't swinging her leg around like this to sort of get it to come through. She was walking pretty straight, pretty even. Okay? Alright, have a go in pairs at that before we move on to the knee, and then we'll discuss how we would actually rehab them and get some equipment out to rehab these ankles. Okay?